So a little bit first of all, this is Diploma Implant Training and our internship. We're based in the UK, that's why we're called the City of London Dental School. We are in fact located in London. This presentation, we're going to describe and give you an overview of the programme. We're going to explain how we deliver this training and what sort of training is needed and expected by your regulators and by the public. Hopefully at the end of this presentation, you'll have a better understanding of the structure of our programme, which we believe is unique. You'll be better able to identify your own training needs and differentiate the problem between confidence and competence. Many dentists are quite confident about the treatment they're providing, but often their competency doesn't live up to their level of confidence, and that's when things go wrong. Now, our overarching university, the universities that award our MScs and our master's level diplomas are Bolton University, and that is a UK university regulated by the UK government. All the degrees awarded by this institution are recognised worldwide as degrees pertaining to the UK and recognised in the UK. Our base, this is our college in London, and we run small group training from this college. In London, it's in Southgate. For those of you who know London at all, it's on the Piccadilly line. So it's about 20 minutes from the centre of London. And the main programmes that may interest those of you in the audience today, although we have about 12 MSc programmes on the books, is our specialist practice of computer-guided implant dentistry and the MSc in the combined specialist practice of restorative aesthetic dentistry and implantology. If you're wondering what the difference is between the two, actually probably very little other than the emphasis of the dissertation, in that the dissertation on the restorative side would be more prosthodontically driven type of dissertation, whereas the computer guided would be more digital in your presentation, in your dissertation. So it gives you a little bit of choice there on the title. And if you sign up for one, you can always jump across to the other if you feel the other title is more appropriate. We do also offer one of the few and only in the world masters in the specialist practice of clear aligner orthodontics as well. If you want to find out about any of these programs, please go to our website. There's more information there. And on the website, you can sign up for an interview at the end of this program. And you'll see there's an option to sign up for an interview regarding the diploma or the MSc programs or our internship programs in the UAE, South Africa, Greece, London, of course. So there's a range of programs there. If you're not too sure, just sign up for one interview and we can discuss what we can best provide for you for you wherever you're based in the world. So now we have a world of opportunity. We're based in the UAE as well, and we work in collaboration with our hosts at RAC Dental School. We also work out of London, in the West End of London, and there's a number of options for you. There's far too many training options to really discuss in this lecture, but I just want to give you some sort of an overview, a flavour, and then really I recommend those of you who are keen to proceed, arrange an interview. Our programmes, broadly speaking, break down into clinical training, and we like this clinical training to be both intensive and effective, and basically aims to get you placing implants, but implants competently and safely. within your various regulations, because in different parts of the world there will be different regulations. And we also provide face-to-face teaching, either at our school in London or at various centres throughout the world. And this face-to-face teaching is also supported by online face-to-face teaching, regular online sessions with your students. In the theory sessions, although you may be doing your clinical training in a number of different locations, when it comes to the face-to-face online, you'll be with students from Greece, Australia, all over the world, in fact. And that gives you a good opportunity to interact and make international friends and form international sort of relationships with colleagues. Also, this qualifications, all our qualifications offer stepping stones to our MSc programs. So depending on the type of program you join and the number of programs you do, depends on the amount that they will give you access to the MSc program, and certain elements of the MSc program you may be able to opt out of because you've already done similar training on one of the other modules. Now, this is our clinic from RAK in the UAE, Ras Al Khaimah, RAK Dental School. It's an excellent facility, very nice, fresh, very, very good lighting, very well organized, and we're very lucky to be working from that facility. This is a student who just the other day, she's been with us only on two sessions now, and she's already quite competently, as you can see, placing implants. Though she recognizes she still has a little way to go. Now, when it comes to the didactic teaching or the lectures, basically, we're looking at how do you achieve and maintain osseointegration. That is the secret at the end of the day. You're all dentists, you're all capable of making bridges and restoring teeth. But how do you actually create or obtain predictable osseointegration, and how do you maintain it? And broadly speaking, we base our lectures are based on, first of all, we look at the host, the general health of the patient, and we explain to you how the assessment of the patient is first and foremost. Not every patient that walks into a surgery is necessarily suitable for implants, and you have to recognize that. They might not be suitable on dental grounds, for example, advanced or progressive periodontal disease or untreated decay. That's an easy one to sort out often. But they may also have medical conditions which, although are not absolute contraindications, do require extra management and present perhaps long-term maintenance issues which we need to be aware of. But when it comes to the host, perhaps the most significant feature is that we're looking or we're trying to determine what the patient's bone is like, what the quality of the bone is like, as well as what the quantity is, to be able to osseointegrate with our implants. The implants themselves do not osseointegrate, it's the patient that osseointegrates the implant. So if they have poor quality bone or medical conditions which affect the biological quality of that bone, it's going to affect the bonding of the bone to the implant. So oftentimes in dentistry, we do a medical history to make sure they're fit for general dental treatment. But with osseointegration, we also want to try and determine what the biological quality of that bone might be. And this all sums up to our patient assessment. It all starts with the patient. It's all dependent on the patient's bone. To a certain extent, that is outside of your control. The only control you really have is whether you take the patient on board, you decide to take the patient on board with no reservations, or you decide to take the patient on board with some reservation. Next, we move on to the selection of your implant design, your implant system, the type of material the implant's made out of. Now, this is completely within your remit. You select your implant system. You don't always have the benefit of selecting your patient, but you select the implant system. You buy the implant system. And there's lots of advertising out there. The big companies do it very efficiently and they're very convincing. But remember, at the end of the day, you are responsible for the implants you place. If you get into trouble, it won't be the system that finds itself before the judge, it'll be you. So we do spend some time on explaining about the implant system, which is in your control. Now, the bone quality and the quantity, again, that's partially within your control because you can do things like grafting or bone augmentation procedures, and there's many of those which we touch on in the program, but we go into more detail in other modules. Needless to say, the most important thing is assessing the patient, which goes back to our host, and making sure the biological quality is good and making sure the quantity is there through grafting. And how do we preserve the bone? So that's semi within your remit. Another area, like the implant system, which is totally within the dentist's control, is the type of surgical protocol, how good they are at their surgery, the restorative protocols they decide to use, the laboratory they decide to use, the restorative components. All that is very much in the hands of the dentist. And again, if you get that wrong, it won't be anybody else's fault but yours. So there's two things that you are totally in your command. That's what system you buy and the type of restorative protocol you engage in and how you plan the restoration. Also, that's totally within your control. And as you can see, all these elements link together to a certain extent. They're not mutually exclusive. They all impinge and influence one another, and they all affect osseointegration. Because if you get any of these substantially wrong, you may not achieve osseointegration, or if you do achieve osseointegration, it doesn't last very long, or you can't maintain it under function. So this is to just give you an idea of the emphasis of where we come from. Now, if you're from the UK, we have regulations which are governed by our General Dental Council, and these is, they use standards set by the Faculty of General Dental Practitioners, and they set the guidelines, and these guidelines are roughly the ones we follow, and they tend to be the ones that are used in varying forms really all over the world. I think there's a broad consensus of opinion about what needs to be in a training program and what your regulators are looking for in terms of training. One of the important factors is your patients must always understand what's going on, especially in the UK. You must provide informed consent. However, it's very difficult to informed consent. That means the patient fully understands what's going on. It's very difficult for you to provide that if you don't know what's going on yourself. So it works on the premise that the doctor understands exactly what's going on themselves to be able to tell the patient. So, and that information must be given to the patient in a way that the patient can appreciate and understand. You've also got to make sure that whatever you do for your patients is based in evidence. There's a lot of materials come out on the market, and some dentists are very gullible and buy into these new techniques. And at the end of the day, they and their patients end up suffering. So we do try to give you some pointers as to what is reasonable and what things, we're not saying are bad, but what things you need to exercise caution about. And the other thing in the UK, which is important, and perhaps not so much in other countries, is the dentist is actually also responsible for ensuring that the manufacture of the implants is of a suitable quality, and that the manufacturer will be around for some time to be able to supply components. So that's something that's a little bit unusual perhaps to the UK. And they also have to take responsibility if the implant causes any damage. Now, this is just an interesting little chart, again, which we go into, but it looks at the reported mechanical complications that arise following implant dentistry over about a 5-year period. And it's looking at single restorations, it's looking at small bridges, and it's looking at full arches. And dentists and perhaps patients tend to think that implants are fit and forget. When you place an implant, just like when you buy a car, you have to buy into a maintenance scheme. These things need to be maintained. If we look at something like a single tooth, which has a screw retained crown, you can get screw loosening of that abutment within 5 years, around about 12%. And that can range anywhere between 6 to 27% in the range. So you could have quite a high amount. And one of the things that affects screw loosening is obviously occlusion, which we look at, but also the quality of the implant. If you have an implant with poor fitting abutments, you're going to have screw loosening nearly every other week, and the patients are going to come back very annoyed with you. And this implant is now bonded to the patient, and you can't replace it easily. So bear in mind, an implant which is cheap is often cheap for a reason. Implant fixed dentures, that's bridges, if you like. Screw loosening on bridges is a little bit less, as you might expect, because there's more support. And if you go to something like full arches, they're actually a little bit higher in screw loosening, about 8%. Loss of retention, that is the thing coming off altogether, about 5% on single teeth. There's no real papers out there to show for bridges, and about 5% for full arches, and that's within five years. So what's all this saying? Well, it's saying expect there will be maintenance issues, and we teach you how to manage these so that when the patients come back to you, you're not in an awkward situation. Perhaps one of the things that is most common with our implant restorations is veneer fracturing. That's the facing on the metalwork. And on a single tooth, it's about 5%, anywhere between 2 to 8% we can see on a single tooth here. So it's sort of manageable in a way, yeah? But if we look at something like a bridge or even a full arch, we can see that the amount of veneer fracturing, or the facing coming off the bridge, gets quite high. It can be almost 13% breaking off a bridge. Now, if a patient's had a bridge, and remember 5 years isn't an absolute, it's within 5 years. So it could be after 2.5 or 3 years, the patient loses the labial facing off of a bridge. Well, they're going to come back and they're going to complain, and they're going to say, well, is this inferior workmanship? Is it a poor laboratory? To a certain extent, they may be right, because obviously if you're using cheaper laboratories and cheaper materials, you can expect that your veneers are going to fracture off more than if you're using more expensive materials and laboratories. So bear in mind that this is a problem that you're going to run into, and you're going to have a method to manage that efficiently and cost effectively. Fortunately, things like the actual frameworks or the metalwork underneath these things don't really go wrong that often, or fracture. Again, screw fracture is quite rare, as is implant fracture. So our main worry with implant restorations is loosening and loss of the veneer at the front. That's our main problem that we're going to have going forward. This is examples of things coming loose. You can see the oral hygiene is amazing here, and the crown has actually come off here with the screw, and you really wonder how this has happened, because as you see the access hole to screw that screw in, you know, how has that happened? This is an example of veneer fracture. This has been in the mouth for some time, it's quite worn, and you've got a veneer fracture. How are you going to manage it? How are you going to cope with that? Another big problem that's now happening is a new disease, which we as dentists have managed to create, called peri-implantitis. Peri-implantitis is probably one of the major causes for late loss of your implants. So you need to know how to manage or cope with peri-implantitis. This patient's developed a small sinus around his implant. We're just gently probing, and you can see there's a lot of bleeding on probing, indicative of inflammation. Again, in this area, we have a mucositis, which is an early form of peri-implantitis. This is more advanced. This is called mucohyperplasia. And you can see here how the gum, this is on full arch, how the gum is almost becoming very fibrous and swollen. And this happens around full arch restorations where the patient's oral hygiene just isn't up to it. So you need to learn how to manage these conditions when they present, because you've placed the implant, so you're responsible. How does our program work when it comes to these things? Well, we do group online treatment planning sessions. And in these sessions, we will plan a case like this. Maybe this is a single missing tooth, and we engage, or we get our participants engaging in using CBCTs right from the beginning. Now, many of you won't have had access or know very much about CBCTs, but it is the way implant dentistry is proceeding. You're going to be expected more and more by your patients and by your legal organizations and by your regulatory bodies to have a CBCT done before you place implants. At the moment, many people still use OPGs, perhaps PAs partly, and that is acceptable. PAs are acceptable, especially when it's coming to look at individual bone level around an implant. They're very good. When you want to look at the fit of a restoration on an implant, you can't get better than a PA. I would say it's better than a CBCT PA for that. This is just a quick overview on using a CBCT to help plan our case. Now, what we do is we take impressions, and one of the first things we can see from this occlusal view is we have got spacing in the arch here. This is quite a broad space, and the spacing here, and we have to discuss with this patient, one, his oral hygiene needs to be improved, and two, when we come to place the final restoration, does he want that gap closed, or does he want a space produced? Because that will affect where you might end up positioning the implant, because you don't want to be having these conversations once the implant is taken and you don't have much option. Always assess the patient's occlusion. We're fortunate in this instance that the patient has got a full intact occlusion. There's no periodontal disease. There's guidance on the canines on the patient's right-hand side. This is a luxury that we don't always have. Here we can see a actual view. Now, if you don't know the views or the names for the various CBCT views, this will be covered in the course, but this is called an actual view. And this is actually a scan of the model that was taken of this patient. It's called an STL file. The CBCT scan files are called DICOMs, and 3D image files, such as this one, are called STL files, stereolithic files. So there are two different types of formats, and the software blends the two formats together, rather like you're using a Photoshop. And you can see we can move up and down through the actual views, lots and lots of actual slices. This is the coronal view. You can see the teeth there, and you can see the area of edentulation. And as we go up, you can see there's a definite dip in the ridge. And that dip in the ridge was apparent on all examination, but now you can actually see where the bone is in relation to the dip. Further down, the dip becomes less apparent. And again, this is all reflected on our 3D model here on the left-hand side of the screen. And we can rotate that model and we can look at, so we can look at both models. One of the things that we try to do, or one of the things we do initially, is we actually trace in the nerve, because we're working the mandible. We need to know where that nerve is. This is the ID canal, and we can trace in. And a lot of the softwares will let you trace in the nerve, and we'll show you how to do that. And the nice thing with the CBCT is that we can look at different slices to really get an idea about how that nerve runs. And we can draw in the nerve, and we can measure the position, or we can measure where that nerve is accurately to within 0.5 millimeter, very easily, accurately, which we, obviously you can't do that on an OPG. So we can go down, we can click, and we can map out our nerve. This doesn't take very long once you know how the software works, rather like using a Word document or using your phone. Once you know how the app works, you're up and going. We're just scanning through various slices there to draw in that nerve. Now, we cover this on the program. We actually give you free software to let you do this. This kind of software in itself is normally £1,500. That's approaching probably 45,000 dirhams, that sort of price. So that is actually given to you free to use, to play with no restrictions. So we can see there's our nerve. We can look at a transverse slice. This is transverse sections, yet another view in our CBCT scan. And we can finish the tracing actually coming out, the nerve coming out into the lip there from that view. So now we've got our nerve traced all the way down through the mandible from the OPG type view, and even on our 3D model, we can see how that nerve travels and where it comes out, and the relationship of that nerve to where the eventual implant is going to be. And on the actual view, these are the transverse views now. We can go back distally. This is the lingual undercut. This is the buccal surface. We get a good idea about the thickness of the cortical plates and also the quality of the trabecular bone. And when we get this sort of image, we can really see the density of that bone, and we know that when we put an implant in there, we're going to get very good primary fixation. And this is going to help us on all sorts of things, like whether we want to do immediate loading or early loading, whether we want to do immediate placement, even to the effect of how many drills we're going to need. Because if we see that the bone is very soft in that region, not very dense as we can see here, we can say, we really don't want to be drilling up the full length of our drills, because if we go the full length, or sorry, the full diameter of our drills, we won't get optimal primary fixation. And we know primary fixation is very important in achieving osseointegration. So also, it's not just telling us where we're going to be positioning it. It's not just telling us about the anatomy of the site, what we need to avoid. It's also telling us about the surgical protocol and possible restorative protocol. Just by looking at this image, we can tell all these things. And we can say to ourselves, right, we now can place our implant predictably in this area. Now, from a CBCT scan, you could just leave it at this. You could just say, right, this is as far as I want to go with it. I know where the ID nerve is. I can switch the nerve. I can switch the bone in and out. I can see how the nerve is in relation to the teeth. You can do these kind of things with the CBCT scan, but there's extra things you can do where you move it to the next level. So we can look at the scan as just a diagnostic tool for looking at the bone and looking at the anatomy, or we can now use it as a guidance tool to actually help us plan and position our implants. So with this software comes a library of implants. These are three-dimensional models to scale from the engineer, if you like, from the manufacturer. And you can click on the implant that you feel you want to use. In this situation, we're using a 3.75 by, it looks like we've picked the a 10 millimeter one there. So we can pop that in. And then what we can do is we can just drop that into the area that we feel our implant needs to be in. And we're just going to start off by, as I say, roughly planning it just to get an idea of what we're doing. So we've clicked that. So we've taken the implant from our library and we can angle it in the mesiodistal position because this is just a 2D view at the moment. Looking at the OPG, and we can position that mesiodistally, and we can position the angle mesiodistally, and we can angle it from the top or from the base. Now we're going to, obviously we wouldn't want the implant to be this far coronally, so we click on it and we move the implant down to where we think we want it to go. And although it looks like I'm being a bit drunk, if I was to stick it here, it goes red because I'm obviously in the nerve. And I'm just positioning that now to roughly where I think it wants to be. May not be, looks all right mesiodistally, of course, but we don't know what's happening to that in a buccolingual position, do we? And that's where our transverse views become very, very useful in that we can now see, okay, mesiodistally, we're spot on, but what about buccolingually? Where do we need to be here? If we left the implant in that position, obviously we're going to come out labially, it's not where we want to be. So now we're going to position that, and maybe we're in the middle of the ridge there. We're going to position that in about the middle. And some of you may notice the bone does look very dense at the apex of that implant. You can see how the density of the bone seems to have increased in this area here. And that tells you that when you're drilling, maybe the drill is going to find resistance near the end, and you're going to have to be a bit heavier just to get through that bit of bone. Sometimes you hit something hard and you want to back off because you're not sure what you're drilling. Well, automatically the program is telling you what you're drilling. Now, from the 3D view, we can actually look at how that implant is coming out. So although mesiodistally it's correct positioned, although buccolingually it's correctly positioned, if the implant was to come out in that position, the crown would be too far lingually positioned. So we need the crown to be in line with the other teeth. So we need that emergence profile, if you like, not to be here, but to be more over here. So this is the benefit of this software, and this is the benefit of using it in the training, in that you get to place the implant virtually like this on your patients before you even touch the patient. You're aware of the issues, you're aware of the restorative issues, you're aware of the anatomy, you're aware of the surgical protocol that you might need to use. You've got all this information. And these are the sorts of questions that an expert will answer as they're going along through the procedure because they have the skill. But if you're a novice and you run into any of these problems, you haven't got the time when the patient's there to actually try and sit down and work out what's going on and problem solve. You've not got that luxury. So this allows you to anticipate what the issues might be and to play with things virtually. It's not going to harm the patient. You can do it in a very relaxed environment. You can send the files to colleagues and they can help you position it. You can discuss it with friends. This is so much better than in the old days when we used to just have to pray that we were doing things in the right way. So here the implant's been placed way, way too far to the lingual, and that may seem to you to be an impossible situation. Why would a dentist ever place an implant like that? But many novices do end up placing their first implants like that, and it's an absolute disaster. And whereas in the past, people were a little bit more forgiving of it because it wasn't known to be a problem, now because we're very much more aware of these situations and there's very much more people doing implants and experts such as myself in the field, we know when things like this have happened. This has been placed too buccally and there's a dehiscence. Again, if you're an experienced implantologist, you maybe don't need to, you've got skills, you know how to conceptualize this in your head. You don't need this extra help. But if you're starting out, this is invaluable because it lets you, as I say, predict where the implant's going to be, what the restorative challenges are going to be, how you're going to drill the bone. It gives you all this information from the start so that when you come to place the implant, you have a lot more knowledge. Now, on this particular one, we're going to just confirm now whether we're happy with the dimensions and the positioning of the implant. Now, this is a 10mm implant. And to me, it looks a little bit, it seems a shame that we can't go for perhaps a deeper implant. And you could, if you want, go for a wider diameter implant, and you can change the implant selection according to what you feel. Myself, I tend to plan for about 3.75 by 12 as usual. That's a sort of standard size. I don't normally plan to 4.5. I plan to 3.75 diameter. Even if the bone is there for a 4.5, with students, I recommend that they plan just for the 3.75 rather than the 4.5. Why is that? Well, because in these situations, there's very little evidence that a bigger diameter is going to improve your success rate. But there's lots of evidence that in novice type dentists' hands, they tend to over-prepare the site. And if they over-prepare the site, then what happens is if they've already over-prepared the site at 4.5, there's nowhere else you can go. You can't go to a bigger implant maybe, or maybe you've run out of bone. But if you prepared the site for 3.75 and the implant's a bit loose, or maybe your drilling hasn't been that accurate, or you haven't used the drills with a steady hand for whatever reason, the actual osteotomy site is slightly oversized so that the implant is loose, you can take that out and you can replace it by the 4.5 with no problems at all, and it'll engage. So it gives you that fallback position to be able to go up bigger if you need to. It also allows you, whilst you're developing your drilling protocol and understanding how to work the bone and how to drill it, it gives you that safety margin, because obviously you're using less drills. So the less times you go up and down, the less chance there is of you getting your angles wrong and having a problem that you need to sort out. So this is why I suggest that you always perhaps go one diameter down. It's a problem that we see when we're teaching students to begin with, is that they don't seem to be able to assess the bone quality. That is, it's not its biological quality in this instance, but its mechanical quality. And whenever you ask them, oh, does the bone feel dense? They nearly always say yes. But you can see it's not dense. You can see the drill's just falling in there. It's like it's going through fresh air. Those situations, you don't want to be going up the whole drill sequence, just like, you know, you're a robot going drill 1, drill 2, drill 3, drill 4 for that implant. You need to drop back. Now, with this position, with this person, we know we've got dense bone, so we will be going for the whole drill sequence for a 3.75. Now, we're keeping the diameter the same, although we could. You can see there is the option to go wider here. But I am going to increase the length of that implant because I've angled it slightly. So I've got the length there. So I'm actually going to go through that piece of dense bone. And because it's a narrower diameter, I can place the implant more buccally. If it's a wider diameter, I have to move the implant more palatally and often or more lingually, and often our problem is with the buccal bone because that's where you've got the lack of bone. And because you've got that dip in the bone, there's a tendency to want to position the implant too far towards the lingual because you're missing buccal bone. So you've got to try to compensate for that by moving the implant as far buccally as you can. The only other way of dealing with this is, of course, to graft the area. But it seems quite a shame to have to graft this area when you've got such good wide bone. And I think just by careful angling and positioning of that implant, you can get a really good restorative result without having the extra complexity. Now here, I've just grabbed hold of the implant and I've widened it to 4.5 to show you that we have got enough bone there for 4.5. By going to 4.5, we're actually moving the implant more buccally, the rim of the implant more buccally. So I'm sticking to 3.75, and I'm going to now take away the extension, which is that metal rod. That just shows you where the crown would be coming, and it's giving me an idea of where the implant's going to be in relation to the other teeth. At least it's not coming out too far lingually. It's still perhaps a bit more lingual than I would like, but we want, if we can, to maintain at least 2 millimeters of bone. And I can switch out the teeth and I can switch out the bone and I can see the relationship of that implant to the nerve, and I can zoom up and you can even see the internals of the implant because this is a 3D engineering model of the implant, like an STL file for their implant. It's very precise. You can see the relationship of the implant, the ID nerve, the mental nerve, the mental canal, and you're well clear of that. And so you can see the internal hex on your implant. You've got a lot of information on that. And of course, those of you who go on and do more restorative work from these scans, that's useful information to have also. Just to look at the anatomy and look at the density of the bone. We've looked at the CBCT as a means of positioning the implant. Now, we've also looked at the CPCT as not just those two elements, which is diagnostic and looking for pathology and for placing our implants, but now we're also looking at it to guide our implants, to actually guide our surgery, which is the next progression in this step. Now, to do this, we need a template. These templates are precision-made tools. They're not made from a bag of acrylic that the technician has in the corner, and he roughly puts down. This template reflects the plan that you've generated three-dimensionally. This moves the three-dimensional virtual image. It takes it to the real world, takes it from the virtual world to our world. And this is, we do this through the template. So this is our template. It's not made from cold cure acrylic, it's actually milled. It uses the STL file, and the technician designs this so that it follows the whole positioning of your implant. So you position the template into the mouth, and you can see here that you can check whether the template is down, because there's windows been left in the template. You can see these windows here, and the teeth pop through there, and you can see the fit. If there is any rock on that template, if that template does not fit 100%, you know, don't get a burr to it and adjust the fit surface like you're fitting a partial denture. It's something wrong. You have to stop. You have to get a new template made. You maybe have to do a new scan of the teeth. You really need to go back to the beginning and find out what the issue is. Also, I see sometimes people make templates which only fit a small section of the mouth. I prefer templates to go over the other side, because you know a tripod is going to give you a more stable fit. Now here are spoons. Again, we'll show people how to use spoons. And this whole case is this student's first case. He's planned it 3-dimensionally, and now he's going to be guided. And because he's doing guided, he's not even going to lift a flap. And he makes the holes, and he can screw the implant in through the flap. He can tighten it down, and there is the implant placed. Bit of local anesthetic, not an ID block, just infiltration. Patient will have minimal post-operative problems because you haven't lifted a flap, you haven't done a long surgical procedure. As I say, it's taken about 15 minutes, and that implant has been placed better by this novice than perhaps I could do it freehand, because it's all been planned from a CBCT scan. So this is a very good way to start your implant practice. Later on, you can trim bits off of it as you become more confident and you understand what you're doing and what you're trying to achieve. This is a transfer. Now, this impression was taken at the same time as the implant was placed. So we're now talking about placing the implant. We get the patient in to do a CBCT scan, take an impression. We then get the patient back, and from that scan, we've positioned the implant and we've made a template. We place the implant, and at the same time, we take an impression for the final restoration. Now, we know we can do all this because we know we've got good primary stability. We know we're going to get good primary stability because our X-ray has shown us the density of the bone before we started. So already we know how this is going to go quite predictably. So we do the transfer, which is recording the position of the implant in the patient. We then put a little healing plug on top, and we send the patient away because we don't really want to have to go back and do surgery to find it again. So we just put the plug on top. If for any reason the implant didn't exhibit good primary stability and we didn't want to go on and load the implant early, then what we could do is place the cover screw. And again, there's no need for any stitch. The gum will just fall over the top of it, and there's no problem. When you want to come to find the implant later on, you have a template that you will have kept safe. You just put the template in the patient's mouth, and you inject through the template, and you know exactly where to find your implant. So this is the finished result for this case. It was done within a month. It was just the lab time to do it. But as you can see, it was one CBCT trip, one trip to place it, take the implant, and one trip to fit it. So the whole thing was done in 3 visits. Very, very predictably. Knew exactly the type of result we were looking for. The occlusion we had there is very easy. It's a screw retained restoration. Now, this is the kind of thing that we start people off on and planning. As I say, these programs can lead to other things if you so wish them to. Later on, we can arrange for materials and implant kit to be delivered to your practices so that you can start working by what we call remote synchronous training, which is you do a few cases under our supervision in the UK. In some of the other areas, it might not always be possible. And then we get the scan, we plan it together, and then we send you the template with the implants, with the drilling machine, with all the instruments, with all the gowns, with all the sutures. Everything comes in a box like a takeaway meal. Yeah? And then you just follow the assembly positions like IKEA, but hopefully you've checked all the screws are there before you start. So what's your next step? Well, we've got an evaluation form, which will get those of you who need the CPD, your CPD credits, and Paul might share that with you in a second. And we can arrange, or you can request, a virtual meeting to discuss your individual requirements or any further questions you might have. And this is the link, www.cl, City of London, -dentalschool.co.uk.